We are live.
Good evening, everyone. So today, I welcome you all to this another episode of Strabismus and NEURO-OPHTHAL module. And we have a great speaker today, Dr. Sumit Monga, and he is going to cover a very important topic. Remember, in your exam, whenever it's a long case, either you get a sixth nerve palsy, third nerve palsy, or a fourth nerve palsy. So this class is very important, not only for your practical, also you may get a short note on this, even essay type question. So please stay focused. And I request Dr. Pranita Sahai to introduce our speakers for today, and then we'll move on to the lecture.
Thank you, sir. So, as you all know, today we are in the ninth class of the Strabismus module, and we have Dr. Sumit Mungas of Palsy. We have with us our moderators for the session, Dr. Abhitsa Sharma, who's consultant at DSG Eye Hospital, trained from LVPI in pediatric ophthalmology, and Dr. Gunjan Saluja, who's our ex-senior resident from RP Center in Strabismus and neuro-ophthalmology, who will be moderating the session for the day, and Dr. Anita Gangar ma'am, who is a senior consultant at Gangaram Hospital in New Delhi. And the speaker for today's lecture is Dr. Sumit Munga sir, who's done his master's in ophthalmology from the prestigious Maulana Azad Medical College, following which he's done his fellowship in pediatric ophthalmology and strabismus and neuro-ophthalmology from the LVPI Institute, Hyderabad. He is currently a senior consultant in neuro-ophthalmology and strabismus at Center for Sight Eye Hospital in New Delhi. He's won various awards at both AIUS and DOS for his paper presentations and his work in the field of strabismus. And his keen area of interest is pediatric cataracts, strabismus, amblyopia, and pediatric genetic eye disease and neuro-ophthalmologic disorders. With that, sir, we hand over the dais to you for your talk on third cranial nerve palsies today. So you can unmute yourself.
Sunil, you can unmute now from your admin
Yes.
end.
Sunil, can you please
Yes,
unmute?
sir.
Sir को unmute कर दो.
Sir, continue to share. You need to click and you are unmuted, sir. Dr. Sumit, can you just stop share for a minute? और मैं आपको एक बार just stop. Can you just unmute yourself and then start, sir?
Actually, when I just put that on the share now, my cursor goes off, it's not traceable. So I'll just try once more.
जी.
Yes, we can.
Perfect, sir. Perfect, sir.
Slideshow.
Okay, is it visible now?
Yes.
Yes, sir. Perfect.
Am I audible also? Yeah.
Yes, sir.
Yeah. So thank you once again for the kind opportunity and to have this privilege, on the eve of the Teachers' Day is indeed, an honor. So let's hope that, we have receptive audience also, maybe now and maybe later, at their convenience. So as mentioned, third nerve paralysis, is indeed a very important topic, from the postgraduate point of view. And as I was made to believe that, the main audience is the DNB students. So I really hope that, they gain a lot, from this. So a classic case of third nerve paralysis presenting to us in the OPD would actually present with loss of adduction because the medial rectus muscle is being supplied by the third nerve is involved. So that means there will be an uncontrolled abduction. That's why it will be an exodeviation. Then there will be loss of elevation because both the elevators, the superior rectus and inferior oblique, are also supplied by the third nerve. And hence, there would be depression as a presentation. And if the pressure of inferior rectus is also involved, but then the superior oblique, which is supplied mainly by the fourth nerve, the trochlear nerve, remains intact, and so does the lateral rectus. So basically, there are two functioning muscles the lateral rectus and the superior oblique, which are spared, and hence the exodeviation and the hypotropia, or the eye being down, that's the most common presentation. And because levator papilla superioris is also involved, so there'll be ptosis. There can be pupillary dilatation, and the accommodation also gets paralyzed, as the parasympathetic system is also linked to the third nerve. Now, this is the classical presentation that a person presents with droopy eyelids. He may or may not have the diplopia, meaning thereby that if the ptosis is completely covering the eye, so the double vision would not be there because only one eye is taking the stimulus. Or if there is a congenital uh, third nerve palsy, then the adaptation, the sensorial adaptation would prevent the diplopia from happening. So that's a very important thing, that suppose you see a patient even in adulthood, he or she may not be able to tell you the onset sometimes, but the symptoms of diplopia would tell you that it's a recent onset, or a paralytic in the onset strabismus versus a long-standing congenital strabismus. So I think the basics should not be should not be forgotten by the students, that when you have diplopia, that will be in a visually mature age, that is beyond 10 to 12 years, the imbalance of the eye has been caused. But when you actually have the onset, early in childhood, because of the sensorial adaptation, which includes the suppression, abnormal retinal correspondence, or, the monofixation syndrome, sometimes the diplopia is not there, when you have the deviations happening in the childhood. So specifically in third nerve, we need to be very clear about, the anatomy, where it starts, how is the course, and that actually helps us understanding what kind of symptomatology that the patient would have. So as you can see in this cartoon, that we have a nuclear segment, that means the nucleus of the third nerve, which is basically in the midbrain, the dorsal part of the midbrain. And from there, the nerve traverses into the substance of the midbrain and comes out from the uh, rostral part of the midbrain over the crus cerebri, which includes the corticospinal fibers, supplying the motor fibers to our limbs. And from there, it traverses the subarachnoid space, uh, adjacent to the vessels of circle of Willis. And then, thereafter it pierces the dura mater and enters the cavernous sinus. And then, from the cavernous sinus through the superior orbital fissure, it enters finally into the orbit. And the two divisions, which have been formed in the cavernous sinus, they just are carried on through the orbit, and they supply, the various muscles. And the pupil is also, supplied. Uh, we'll just discuss that more in detail in a while. So you have a nuclear segment, you have a fascicular segment when it passes through the midbrain. Then you have a subarachnoid segment, or which is also called a basilar segment. And then you have the cavernous sinus path and the orbital path. So these are various paths or the courses, through which the third nerve completes its journey. So coming to the nucleus part, the nucleus of the third nerve is situated in the midbrain at the level of the superior colliculus, and it is actually, a bunch of grapes, having different components of the subnuclei. So there is only one unpaired nuclei of levator. It's a midline caudal structure, meaning thereby that one nucleus supplies, both the levator palpebral of the right and the left. So if that is injured by any chance, so you will have a bilateral ptosis. But the other five subnuclei are unpaired. So we have a separate nucleus for the middle rectus, inferior oblique, superior rectus, and then there is a Edinger-Westphal nucleus, which is supplying the parasympathetic component, which is supplying the pupil fibers, the pupillomotor fibers. So if you have these subnuclei apart from the levator, they would be generally, like you have both the unpaired, separate for the right and the left. Now, it is important to note that the superior rectus nuclei, the subnuclei of one side, would be supplying contralaterally to the other side, meaning thereby that if you have a right eye uh, third nerve palsy involving nuclear palsy, you will have a contralateral elevation deficit because the superior rectus of the other side is being innervated by the superior rectus subnucleus of the right side. And the other unpaired nuclei, the Edinger Vespal, the middle rectus, inferior rectus, and inferior oblique, they're supplying the ipsilateral to the same side. So this will be more clear when I discuss, exact case. So generally, a nuclear lesion is very rare in third nerve, but whenever it is caused, it could be due to infarction or a specific hemorrhage which has resulted in a subpart of the midbrain due to a burst vein or a neoplasm, which may be present in the midbrain. So this is a case of right eye third nerve nuclear palsy. You can see that this lady has bilateral ptosis. It's on both sides, maybe asymmetric, more in the right side. And right side ptosis is because the levator papilla superioris was involved, and because it has a single midline caudal nucleus, the other eye pupil is also, other eye lid is also ptotic. And if we check the ocular movements of this person, she will have a contralateral superior rectus. That means the left-sided elevation would be also involved. On the contrary, the same side superior rectus may be spared because that is actually having a supply from the superior rectus of the left side, but superior rectus subnuclei of the left side. But because the inferior oblique, which is also elevator, is also involved, you would have some elevation deficit and that eye also. So you can say there'll be a bilateral elevation deficit more in the left eye. The contralateral side has more elevation deficit compared to the side which is involved. But the bilateral ptosis would be there in a nuclear third nerve palsy, or there will not be any ptosis at all. Why? Because sometimes you have involvement, but the levator palpebral subnuclei is not involved. So if that is not involved, both the pupils will be spared. Both the lids, I'm sorry, I beg your pardon, both the lids will be spared, but you would have, the other involvement in terms of, the whole set of nuclei, like mid being involved. So there will be an adduction deficit, there'll be a depression deficit, and along with the pupillary involvement if the Edinger-Westphal nucleus is also involved. So here, this lady actually had a inflammatory lesion in the midbrain, which was leading to this nuclear lesion. So here was a gentleman, a young gentleman. Unfortunately, he had an infarction of bilateral nucleus, involving the third nerves. So this you can see, you have a bilateral ptosis here. He had a complete, like ophthalmoplegia because there was a bilateral involvement, and he had pupillary involvement of both the sides. And this is also a little rare, but this is one case that we dealt with. Then when the nerve goes away from the nucleus into the substance of the midbrain, it passes through the red nucleus, in the midbrain. So this red nucleus is basically, an area where, there are ferritin deposits, and it appears little dark contrast, on the MRI. So just to recap the neuroanatomy, the red nucleus basically, has a lot of connections to the cerebellar system. And that's why, when the fascicular nerve is passing through the red nucleus, if that is specifically involved, then you would have a hemitremor, of the opposite side, because the cerebellum is, as a balance organ. And apart from the third nerve, you would have a hemitremor of the opposite side. Then as depending on, where the nerve is involved, the nerve, when it crosses the midbrain, or, it crosses the crus cerebri, that means where the corticospinal tracts are being transmitted from the brain to the rest of the body, we would have different involvement. So I'll just come back to that. There are some syndromes, as you all know, that, we have with the fascicular lesion. So if you have a fascicular lesion compared to a nuclear lesion, it would be a little more complete third nerve palsy. Both the pupil and the other uh, somatic innervation to different parts of the muscles would be involved, and you would have a complete ptosis along with the ophthalmoplegia that will be seen in this case, compared to nuclear palsy, where you saw that, sometimes, the ptosis of the same eye, may not be there. There'll be a contralateral ptosis if the lateral palpebral is spared. So these are the common syndromes that you would need to know, as a postgraduate. And it's a very logical approach. If you know the path of the third nerve, then it's not difficult to remember that at the level of the red nucleus that we were seeing in the in the diagram on the right side, you can see the nerve when it traverses the red nucleus. If you have specific involvement of this, then you will have an ipsilateral third nerve, a complete third nerve with contralateral extrapyramidal signs. We just talked about the cerebellar connections that, are passing through this red nucleus. Then you have a Weber syndrome, when the nerve, the oculomotor nerve, is passing through the cerebral peduncle. Then you have the obviously third nerve involvement with the contralateral hemiparesis, because there are crossed fiber tracts, the corticospinal fibers, which are coming from this part of the brain, and these are coming from the cerebrum to the brainstem and then to different parts of the body to the spinal cord. Then you have the Nothnagel syndrome, which occurs at the level of the cerebellar peduncle, a little further away when the nerve moves away. And you have ipsilateral third nerve palsy with cerebral ataxia. And this combination of Benedict's, that is, when you have a hemitremor and extrapyramidal signs, as you saw in the Benedict syndrome and the Nothnagel syndrome, if you have in this in combination, if it's a bigger lesion involving, all this, a bigger infarct, then you actually call it as a Claude syndrome. So apart from the nuclear etiologies, where we saw that infarction, hemorrhage, and neoplasms were the cause, in this situation, you can have a demyelination as an additional pathology, which can affect the third nerve. And that is why actually we need to be careful that when we order the neuroimaging, depending on where exactly are we suspecting the third nerve, we have to order the imaging accordingly. So further to, the midbrain, when the nerve, the oculomotor nerve traverses further ahead, this is one space where the nerve is in isolation, meaning thereby there are no other nerves, which are in close proximity. So that is why actually when you see isolated third nerve palsy, you should be suspecting that possibly it is a subarachnoid space that, this nerve is being involved, because this is one area where the third nerve alone is involved. In the nucleus region, you have other signs, as we just saw, all these syndromes, the fascicular, in the fascicle region, and specifically the nuclear palsy, has certain specific, you know, telltale signs, to suggest that, it could be nuclear. But when you have just a third nerve palsy with no other contributory neurological signs and the other nerves are relatively intact, think about the subarachnoid space. And two important, pathologies where we need to be aware that, this can happen is a trauma where the nerve, when it reversing the subarachnoid space, this is in region, where the dura mater, gets consolidated and forms a tentorium cerebelli. Tentorium cerebelli, simply speaking, is that, we have the cerebral hemispheres and there is a, brainstem down. So if you have those cerebral hemispheres, there has to be something, firm that should be supporting the weight of these cerebral hemispheres. So what happens is that, the dura mater, it gets consolidated and forms something called a tentorium. So it's a very firm structure. So when you have trauma, suppose there is something, there is a hematoma formed, or the impact is so severe that the whole cerebral hemisphere, it just can be displaced to one side. So this pushes the oculomotor nerve across the tentorial cerebri and the tentorial passage, which is basically a firm structure. And initially, when the compression is mild, we may just have a mild meiosis, but when you have a proper compression, happening in the third nerve, then obviously there'll be a mydriasis, because the pupillomotor fibers, they are superficial and they can get compressed, and that will be, you know, uh, visible by the pupil involvement in a third nerve palsy, apart from the other third nerve extraocular muscles, that is getting involved. So head trauma is a very prominent feature which affects the subarachnoid course of the third nerve. Another very important and life-threatening cause of third nerve palsy in this area is because the nerve is in proximity to the arteries of the circle of Willis, specifically posterior communicating artery, which we in common parlance calls as PCOM, because this is a posterior communicating artery which is connecting the posterior cerebral artery with the middle cerebral artery, the posterior and the middle circulations, of the brain. So here you can have an outpouching of this PCOM artery, uh, which is basically an aneurysm. Now, when this aneurysm as such presses on the oculomotor nerve, it can lead to third nerve palsy, a complete third nerve palsy, which will be painful and which will be involving the pupil, because the pupil fibers are on the superficial aspect of the third nerve. And this is a very important sign, the pupil involvement. That's why, because if you miss this and if you, uh, let this just go, having a casual approach, the person can die, because the aneurysm can burst and it will not give you a second chance, and the person can just collapse. So he may just, be labeled as a third nerve palsy and just, subject to certain investigations, which may take their own time because of the logistics involved. That's why it's very important to suspect, and to be on the safer side, order the investigations in choice. We'll just, talk about it in a while. So if we just specifically talk about uh, this particular thing, I think I had the order of the slides was just disturbed. So I'll just come back to this. So what we were saying was that the oculomotor nerve, has a trunk and it has a outer surface. The outer surface, the exterior surface of it, is generally supplied by the pile vessels. The arteries or the vasculature, are supplying the pyometer of the brain. So when you actually have a compressive lesion, it would really put a pressure on these bile vessels, and because of the less blood flow, the outer surface of the oculomotor nerve would be involved more. So here lies the pupillary fibers, and because they are little peripheral in the subarachnoid space, when the nerve is exiting the midbrain and going towards the cavernous sinus. So if you have a compressive lesion from the outside, it would affect the pupillary fibers early and the pupil involvement would be there. But suppose it's a microischemia because of, say, diabetes, blood pressure, or any other lesion, they would affect the vasa nervorum. The vasa nervorum means the blood vessels which are supplying the main trunk of the oculomotor nerve. Here, because they are traversing the sheets of the oculomotor nerve, the endoneural and other sheets, and they're directly going, the blood vessels are going directly to the main trunk. when you actually have involvement of these blood vessels, it would not really affect the peripheral fibers to start with. If you have a gross infarction, obviously involve the whole trunk, then of course because of the atrophy and the spreading of the infarction, possibly you may actually have pupillary fibers also involved later on, but not to start with. So that is why it's important to realize that when you have pupillary involvement, which is early, along with the extraocular muscle paralysis that you're seeing, in a case of third nerve palsy, suspect that, you could have a compressive lesion rather than a vascular lesion. And that is the whole concept, that why pupil is specifically, looked for in a third nerve palsy. You will not have pupillary involvement always, but specifically when it is a complete third nerve palsy, meaning thereby there is an extraocular muscle paralysis. We just talked about, the different subnucleus. So if you have a complete involvement, not a partial third nerve palsy, meaning thereby that it's not just the superior rectus and levator palpebral that is involved and the depression is normal. If you have that, obviously it's a partial third nerve. But when you have a complete third nerve palsy, specifically look for the sign of pupil involvement, because in partial third nerve palsy, anyway, you would err on the side that the pupil may not have got involved because there'll be a superior division or inferior division of, the nerves that will be involved, and the pupil, may be spared. So when you have a complete third nerve palsy, do look for a pupil involvement to start with. Now, when we actually have the oculomotor nerve going from subarachnoid space to the cavernous sinus. The cavernous sinus, has certain structures in proximity. So as we all know from our previous knowledge that, there's a pituitary gland on the top, and there's a pituitary gland, which is little, like on the backside of the cavernous sinus. But if the pituitary gland is actually enlarged in some way, it can press on the lateral sides of the cavernous sinus where you have some nerves, and it also can actually affect those nerves. So one of the nerves obviously is the oculomotor nerve on the lateral side of the cavernous sinus, and as you can see, pituitary gland is not far away. The chiasma obviously gets involved, when you have a pupillary involvement by the superior expansion of the pituitary. But when there is a lateral and anterior expansion of the pituitary lesion, whatever the lesion, that we have in the pituitary gland, you can actually have involvement of third nerve along with, the other nerves like trochlear nerve, which are also there, the first part of the trigeminal nerve, and so on. And of course, if you have lesions like keratocavernos fistula, where you have a common, the abnormal connection between the carotid system and the cavernous sinus, then you can have a expansion which can lead to compression of the nerves on the sides. And if you have some lesions, like meningioma, Toulouse-Hahn syndrome, which is a granulomatous inflammation in the front part of the cavernous sinus, those can also affect the third nerve. The importance is that in the uh, anterior part of the cavernous sinus, the nerve, the oculomotor nerve, which was basically an intact trunk till now, it splits up into a superior and an inferior division. So very often we were just talking about, there will be there can be multiple cranial nerves involved. So one of the important things that is asked to the postgraduates is that suppose you have an involvement of third nerve where multiple extraocular muscles is involved, then how do you assess, whether the fourth nerve is is involved or not? So that should be clear that, a fourth nerve, because it's an intorter also, it's a depressor also. So when you have a third nerve palsy, suppose this is a eye, the right eye with third nerve paralysis, which cannot adduct, which cannot elevate, which cannot depress completely because the inferior rectus is involved. But when you ask this person to just look down and in, so there'll be a superior oblique, which would be leading to a little bit of depression. And it will also cause intorsion. So when you actually have these conjunctival blood vessels, as a mark on the slit lamp, you would see these conjunctival vessels or a specific, area where we have focused to intort. And that will tell us that, in the same eye, the fourth nerve is intact or not. So when you have intorsion, that means you have an intact fourth nerve. So this is very important that in these cases, sometimes we have to rely on the torsion action of the fourth nerve, which is its primary action. Then you have the intraorbital course, where we, just to recollect, now we have a nerve which is basically having a superior division and an inferior division. So if you have an affliction of the oculomotor nerve, you can actually have exclusive involvement of the superior division, which is supplying the levator palpebral superioris or the superior rectus muscle. And if you have the inferior division, which is involved, then you can have the middle rectus, inferior rectus, and inferior oblique also involved. Now, the point to note is that the nerve to inferior oblique also carries the parasympathetic fibers, which were coming through the oculomotor trunk. And that's why when you have the involvement of inferior oblique, generally it's also associated with a pupillary involvement. If it is just the inferior oblique, that is involved. And these fibers, these are the presynaptic fibers coming all, through the oculomotor nerve from the Edinger-Westphal nucleus. These are uh, the parasympathetic fibers. Then they synapse in the ciliary ganglion, and through the short ciliary nerves, they supply, the ciliary muscles and the sphincter pupillae muscles. So, which is what, finally is the effector pathway for the pupil. So this is very important to understand. So again, the involvement of the superior or the inferior division is not very common, but one has to be aware that it could be, also, involved separately, the superior and the inferior divisions. And the causes could be either traumatic, vascular, or if there is a space occupying lesion, particularly pressing, on one particular division of the third nerve. So coming back to, what we were saying, that, an isolated third nerve palsy, meaning thereby the other cranial nerves, like the optic nerve, the trochlear, trigeminal, abducent, facial, and then so on, are not involved, and we do not have any other involvement of, the body. That means, you don't have paralysis of, the hands or the legs also, or you don't have any other neurological signs like hemitremor and all. So this is something which we call as an isolated third nerve palsy. And remember, most likely, if this happens, the damage is basically at this subarachnoid space where this nerve was in isolation and it's involved in isolation. So the causes could be either idiopathic. Sometimes, in spite of your all checks, you really are not able to figure out, what's the cause. Then you can have vascular causes, the microischemia contributing, to the isolated third nerve palsy. And then you have a very life-threatening, important cause that we discuss, the PCA aneurysm, the PCOM. It's PCOM aneurysm, not PCA. And then trauma. And then you can have miscellaneous causes. And important to realize that, not to forget, in very elderly individuals, you always have to always, rule out temporal arteritis or the giant cell arteritis as a cause, which can also lead to the involvement of the vasculature and lead to a third nerve paresis. Then sometimes there are some brief episodic episodes of third nerve palsy, which may just come and go. So always think about, migraine. Migraine, which we know that, like has a vasculopathic origin, sometimes can lead to both a third nerve palsy and a severe episodic headache. Then you can have compression, which may or may not get relieved spontaneously. That's why the third nerve palsy may happen and go. And then you can have a ischemia, which may be aborted at times. So sometimes you may have a ischemia, the person may feel double vision. And at that time, if you just test that, you would have some signs of third nerve palsy, but then, it may just resolve, very quickly also, because there'll be restoration of the blood supply that can happen. So these are all possibilities that we should be aware. And sometimes, when you have intracranial pressures, which are altered, sometimes, you have increased intraocular pressure because of any reason. Then, the third nerve palsy, because the brain there is a midline shift and the third nerve gets compressed against the tentorium, that can lead to these kind of situations. And always, always remember the great mimicker of myasthenia gravis, where if you have a complete third nerve or a partial third nerve and there is no pupillary involvement, always think about myasthenia also. Although, myasthenia, of course, you have other signs like ptosis and the body weakness, the fatigue, all those things can give you clues which you will not get in a just an isolated third nerve palsy. So just to coming to a couple of cases. So this lady actually has a partial third nerve paralysis because this lady has a partial extraocular muscle involvement where you have decrease, depression, there is decreased adduction, in the right eye, and there is, pupillary involvement also. So here, because we had suspected a PCOM aneurysm, we were quite focused on exactly, ruling out things. So using a catheter angiogram, the intervention radiologist could actually find a PCOM aneurysm, which was indeed pressing on a third nerve, leading to this kind of thing. So we didn't really wait for the third nerve palsy to just, like bite by. It should be a very quick decision. And how do we have to actually approach this situation? Suppose you see this patient in an OPD. See, as we just mentioned that, like if you're suspecting PCOM aneurysm, even if you're suspecting, you don't have very clear-cut signs, you don't have a pupil which is very clear cut, there's a dilatation. Sometimes when you see the person, the pupil or the third nerve palsy will be in a stage of resolution. So that is very important to understand that pupil may just be very sluggish in reaction, or it may just, be recovering from that stage of, a dilated state. So you will not get a classical sign of a dilated pupil always for you to label it as a uh, pupil involved third nerve palsy. So even if you're suspecting, ideally, you should be actually sending the patient for a urgent CT and a CT angiography. Why a CT and a CT angiography? We should be aware that what we are trying to do. Suppose there is a small burst of this aneurysm. We would actually get a subarachnoid hemorrhage, which will be picked up in a CT in 10 minutes. It's a fast investigation. So that's what CT will tell us. CT will not tell us whether there's an aneurysm or not. The aneurysm will be picked up in the A part. A for aneurysm, A is angiography. So CT angiography, because it is fast to organize. When you say MR angiography, it takes time. The person has to undergo 45 minutes, 1 hour, and when they go, obviously they don't have an appointment, in the emergency. So ideally, these patients should undergo a imaging which is fast and easily accessible in an emergency, which a CT and a CT angiography is there. That's the first step. And then to qualify, if you really suspect an aneurysm, because small aneurysms, even a CT angiography would miss, then you can actually let them actually do the other things. Like sometimes they want to do a distal subtraction angiography. Again, an A. So always remember for aneurysm, we are actually, doing something with an A. CT angiography, distal subtraction angiography, and why an MRI and MR angiography also sometimes we want to do, because see, at this point, when you have seen, the patient to have a third nerve palsy, you don't know whether what will come. So things like demyelination, things like tumors, would not get delineated more on CT. You would require, the MRI evaluation, which is better for these. But they can wait. First, a basic screening by the CT imaging, including an angiography, and then, the MR and angiography in a day or so, or whenever that is possible. So this is one case that I would like to show you, that this is a representative case where when the person was referred, with a headache and a third nerve acute palsy, the person already had started to having a subarachnoid hemorrhage. And as we were talking, if we wait, for the routine angiographies and other things to materialize, obviously we'll miss this part. So always, when you have an acute third nerve palsy and you are suspecting a aneurysm as one of the compressive pathologies, try to do a CT imaging immediately so that we rule out if there is anything gross in form of a subarachnoid hemorrhage, and the further tests of the interventional radiology, like in this case, the finally catheter angiogram nailed the diagnosis. So very often you actually find that you see the patient late when the patient has recovered from the third nerve paresis, and there are very little residual signs. Like in this lady, when you see this patient has a reasonable alignment in the primary gaze, and when you look at the other gazes, the person has elevation deficit, slight depression deficits also. But what is more remarkable is that when she is looking down, you see that there is a elevation of the lid, in down gaze. Normally the lids follow the contour of the globe. So when you have a thyroid case, when you actually have the lids, which are retracted because of the thyroid ophthalmopathy, affecting the lids, you call it a von Graffe sign. But when you actually have a lid which gets retracted, when you look in down gaze, in a case of third nerve palsy, recovering third nerve palsy, this is basically an aberrant regeneration, meaning thereby that, when the third nerve palsy was recovering, specifically from a traumatic or a compressive cause like meningioma, you have a regeneration of fibers, the axons which happened, and because of the misdirection of these axons, that means, when you look down, normally the fibers are supposed to innervate the inferior rectus fibers are supposed to be innervating the inferior rectus only. But suppose it's in a recovery phase, it will probably innervate the fibers, which are going to the levator also, because it's all in the trunk. So because of this, you have aberrant regeneration, which can lead to both the lid involvement, the retraction, in different gazes, the depression as well as adduction, and you can have a pupillary involvement also. If you carefully see, the pupil, when you move the eye in different directions, sometimes you'll be surprised that the pupil is actually getting, affected. The reaction is occurring, when you actually moving the eye in different gazes, which normally shouldn't happen. So this lady actually, had a meningioma uh, leading to a third nerve palsy, which had recovered to some extent, but then, in the recovery phase, she had this apparent regeneration. Now, coming to the basics, when you actually, as a postgraduate or a, learner of strabismus, you must have actually had this in the initial modules that we always talked about. In paralytic strabismus, we have something called a primary deviation and a secondary deviation. So just coming to that, as a representative situation, that suppose, you have a left eye, which cannot elevate for some reason. We are calling it as a monoocular elevation deficit. Suppose, it was because of third nerve. Let's suppose so. So when the eye, which is paratic, that is the left eye in this particular gentleman, is fixing, just imagine that, this eye would come from its hypotropic position, because normally you have an elevation deficit. The unopposed muscle is the inferior rectus. It would have taken that eye down. So the normal position of this eye is actually in down position, that is in depressed position. So when you are making this person fix with this eye, this would be a paratic eye which would be fixing. And just imagine, how much extra effort, this person would be making to fix with that left eye. And when you actually, fix with the left eye, the paratic eye, the same effort would be transmitted to the elevator of the other eye because of the Herring's law. Okay, and that is why when you actually have this extreme right image where the person is fixing with the left eye and you are seeing the deviation in the right eye, so this would be, fixing with the paralytic eye, and this would be a secondary deviation. That means you have a deviation, where the paralytic eye was fixing and the sound eye was getting deviated. This would be more. So just consider the middle image where you have a sound eye fixing. That means it requires a minimal effort because it's a normal eye to really fix, at a target, a visual target. And the other eye is actually, kind of resting its normal paralytic position. So this deviation would be less. So this is called the primary position. So when you have to place a prism over the paralytic eye, you will get a primary deviation. So this is triple P. There is a PPP. And when you have a prism, which you have to place over the sound eye, this would be a secondary deviation. So in paralytic strabismus, secondary deviations are always, greater than, the primary deviations. So this is something, which recapitulate what we have just, understood in detail, that when you have a third nerve paresis, which is associated with other brainstem signs, then obviously you go in a different path. When you have a isolated third nerve, say suppose in a younger patient, and specifically in isolated third nerve palsy, you would be more inclined to actually image and look for life-threatening situations like a cerebral aneurysm versus a old elderly gentleman, or a female, with vascular risk factors. And specifically, if it is a pupillary sparing complete third nerve palsy, then you would probably, just evaluate the risk factors of the vascular risk factors and not really image. But again, as I said, pupil involvement is not infallible. Even if you're waiting, do, have a close follow-up and see whether this patient is indeed recovering. And the pupil involvement may just come with time. Always be on the lookout for that. So just a brief review of, the management. Obviously, if you have a acquired third nerve palsy, that management would be a little different compared to what you have in a congenital third nerve palsy. When you have a child, with congenital third nerve palsy, the amblyopia management also, comes along with the other aspects of management. So you would want to actually avoid that amblyopia by aligning the eyes, by doing the occlusion, the patching of the sound eye. And when you have a diplopia management, which is to be done in the adult situation, apart from the control of vascular risk factors, you can avoid, manage the diplopia either by the use of frosted glasses, segmental occlusion, or by use of prisms to control the double vision. Remember that in the micro ischemic third nerve palsy, things do improve, in few months. If you do not have improvement, which is significantly happening in the first 2 months, say about 4 to 6 weeks, I would say, then always think about neuroimaging that patient, because you may be absolutely, going theoretically right. But if that patient has something else, you would repent later. So always err on the side of, imaging if that is a possibility, and the patient, can afford it, and you can actually afford it in your setup. So just to cover the surgical management also, so that depends exactly, as a fallout of this third nerve palsy, how the situation is. So this is a third nerve palsy where the person has recovered quite considerably. You can see that there is a very small adduction deficit in the right eye, and she generally has a good aligned eye apart from a little exodeviation that she had, which led to the diplopic vision. So we just did, a recession procedure in this right eye because the adduction was decent. So just by tackling the right eye, by doing the routine RNR procedure in the right eye, we could actually get a good aligned eye in the position, which helped us manage the diplopia. Now, this gentleman actually had an orbital fracture, so he was managed with the orbital fracture first and the third nerve palsy when it led to a very large adduction deficit and a very large exo. So what we did to obviate that to some extent the situation, we did something called a vertical rectus transposition. The muscles that were still acting, the superior rectus and the inferior rectus, which had actually recovered quite a bit, in this particular case, we use the power of those to actually transpose it to the medial quadrant to improve the adduction, which improved, say, by 3 units or so. But obviously, we could not really help this gentleman completely. So in a case of aberrant degeneration, sometimes, you can have an advantage that, sometimes when the ptosis improves in a particular case, so you can actually operate the sound eye, that is the eye which didn't have the third nerve palsy, and that can help you to really impose a fixation duress on the normal sound eye. Like in this case, the third nerve palsy was in the right eye. We knew that he has an exo deviation primarily in that eye, but because his situation was such that his aberrant degeneration was improving when the right eye was adducting, we chose to operate the left eye, and that helped us to improve the ptosis along with the alignment in the primary case for this patient. So when you have a misaligned eye, the exodeviation, and a large abduction deficit, conventionally, there were some lateral rectus weakening procedures because normally there are two remaining muscles, lateral rectus and the superior oblique. So what we used to do is we used to actually just detach the lateral rectus, take off the power of the lateral rectus from the eye, which is misaligned, uh, the paralytic third nerve palsy eye, and either attach it to the periosteum so that it doesn't reattach back, or you would actually do something called a globe anchoring procedures, where you just anchor the globe to something which is fixed, like uh, the middle aspect, the middle quadrant, the bony trochlea that you have, or the middle orbital wall. So basically what we are trying to do is we are trying to fix the grossly misaligned eye to the central position, obviously at the cost of the complete loss of movement. You would not have abduction, you would not have whatever depression that superior oblique was doing. So these are all were having limitations, and were not very popular uh, for obvious reasons. So what is really now come is, I just want to show you an illustration. We just made one illustration, just see this video. So if you have a lateral rectus, if you actually split it, like that, and to the equator, that's the only functioning muscle, apart from superior oblique, mind you. So you just take it underneath the superior rectus, the superior oblique, and bring it nasally to, to the middle rectus muscle, both in the superior and the under quadrant. So you are splitting it and attaching the two halves of the lateral rectus to the middle rectus of the other side. Obviously, you have a large adduction deficit, and the eye is not adducting. Now, in this case, also we had a little hypotropia. So we actually did a frost suture on the top of, the attached thing, just, and this is what you can see, that, the splitting has to be, till the equator. So this will give you an insight into, what is called medial transposition of split lateral rectus. This has actually improved the outcomes, nowadays. And this is the in thing that we are actually doing for many other cases, which were not really getting okay, with the previous procedures. So I think we should be aware of this, as a postgraduate. Obviously, you have all these procedures, all these experiences, which has empowered, the evolution of these procedures. And just to tell you that, when we had these nasal transpositions of the lateral rectus, we had some complications like, seizure detachment of the retina. And then, of course, if not done properly, we may have other issues. So basically, what you should remember is that if you have a decent abduction, the third nerve palsy has recovered quite a bit. Possibly you can just do the RNR, the resection on recession of the same eye to align the eyes in the primary case. Always remember, the goal is not to have a decent alignment in all the gazes. It's all about functional gazes, the straight and the down gaze. If you are able to align the eyes mainly in these two gazes, and make the patient diplopia free. That is the aim. And that you can actually do by variety of, the methodologies and sometimes just the medical management, we just discussed. So also a word about ocular nerve regeneration. This is also work in progress. And this would be the ideal thing that, if we can regenerate the other nerves, as we are, working on the other nerve palsies, in the body, why not, about the cranial nerve palsies? So this is obviously a work in progress, but just to bring the insight that, this is also one thing. Just a quick, some questions I had, the Viva was questions. I don't think we have time. So I think the PDFs that we would be actually giving, at the end of the things, probably this is something, which would be uh, helpful for you. That's what I feel. That's why I thought, the whatever the common questions, that we had from the examiners, I have just put the questions as well as the answers. I think that'll be helpful for the students. And thank you. I stop it at that and leave it for the moderators, please.
Thank you, sir, for that wonderful lecture. It was an elaborate lecture and covered almost all the points for third nerve palsy. You had already given the question and answers which are commonly asked in the Viva at the end by yourself. So one more thing that I would like to ask you, which we can ask in the Viva, is about the role of hair screening in these. The
Yeah.
role of hair screen, least charting hair screening for these patients, and what would be the findings for the same, and what are the signs of what would be the signs of acute third nerve palsy if the patient is presenting?
Yeah, so very rightly pointed out. So basically, in any case of paralytic strabismus, when you have this, obviously diplopia charting and, the hair screen, which is basically what you're trying to do is you're trying to fix with the one eye and using the principle of haploscopy, where you're actually projecting two different targets to two different fovea of the eyes. You're trying to chart the, movements of the other eye. So if there is a limitation, of movement in one of the eye, underaction, overaction of any of the muscles, then you would, really get a particular chart. Like in a third nerve palsy, what you're expecting is that there'll be a underaction of, the elevation, the adduction, the depression, and the corresponding, spike of the other eyes. When you will be charting, the normal eye, you would actually have an eye which will be, even going beyond your charts. The charting, when you do, you just mark it by arrows. And obviously, the point to remember mostly is that if you're presented the left and the right chart, and the examiner would want to know from you which is the involved eye. So always the eye with, the small area, is the eye. But at this point of time, you don't know whether it's a paralytic strabismus or a restrictive strabismus, mind you. Then obviously, you would do FDT and FGT, to see that part.
And then what are the signs of acute palsy, acute cranial nerve palsy?
Yeah, so
Because
acute third nerve palsy is basically a general term that means, you can actually have extraocular muscle involvement. So if it's a complete third nerve palsy, you will have involvement of, all the muscles which are supplied from the third nerve, and the pupil may or may not be involved. As I said that, like you have all the combination that we have seen. Sometimes the pupil may be involved partially. And then when you see the patient, after 3-4 days, if you have that, kind of follow-up that is going on, you would have a proper dilatation, which is coming. Or if you see the patient in the second week or the third week, the patient has been referred, because most cases are referred, from neuro-ophthalmic time, they take time. So by the time you would see that there is only a sluggish, kind of involvement, and it doesn't really qualify as a pupillary involvement, but you would still err that, like people may be involved in this and I cannot take chance, and it may be painful or painless. That's an important aspect. Sometimes we think that, like being a diabetic, like when we heard about, heart attacks, these are silent heart attacks. But remember that when you have periorbital pain, even if the patient is diabetic, that pain may not mean that it's always a aneurysm. A diabetic third nerve palsy may also have a pain because the ischemia induces that pain. There are pain fibers, along the nerve, and that induces the. So painful is not a very good criteria to say whether it's just the aneurysm or the otherwise.
Yeah, so Dr. Monga, this was a very nice lecture. I just, can you hear me?
Yes, ma'am. Yes, ma'am. Please carry on.
Yeah. Yeah, Dr. Gunjan, you were saying something.
Yeah, so sometimes patients with aneurysms, they might have, or with a small bleed in the subarachnoid space, they might also complain of headache.
Yes. It's the worst headache of their
And
life.
thunder,
That's what.
that is very difficult of that. Yeah, so second thing is with partial third nerve palsy, which can be seen. And then, sir, one more last question is about the management with ptosis and role of crutch glasses and other things in
That's a
patients who are.
very important point Dr. Gunjan brought up. See, we talked about, the alignment part, but suppose, the patient has a ptosis, which is not resolved. Now, one would be tempted that, like, let's probably do the ptosis surgery, but remember always to see the bells, in this case. Because again, the bells may not be very good in this case. And if you actually have a ptosis, which correction has been done, we see there in practice, and we see corneal exposures also happening. So a temporary crutch glasses would be a little better, if you don't really have bells. And even if you are actually wanting to just correct, and remember, a ptosis correction without a misaligned eye being corrected, that will make the patient's life worse because the diplopia would get manifest.
Yes, yes. Okay, thank you, sir.
Thank you.
Yeah, so I just wanted to tell the PGs that the more you remember and revise the anatomy, the better you will remember all the syndromes and where what is happening. So that is the most important thing to remember for any cranial nerve palsy. What is its path? And if you know that, you will know how and what syndromes are manifesting, and clinical examination will also be easier.
Absolutely. So I think I took a little long. I apologize for that.
The topic is also very long, sir. We
Yes.
have covered almost all the aspects without leaving, and I think it is very important for the postgraduates to understand the nuclei and the subnuclear part, as well as the fascicular part and the syndromes which are there, so that they
Yeah.
don't get confused in the exams. Very nicely said, very nicely covered.
Thank you.
Thank you so much, sir, for taking that exhaustive class on this topic, sir. Thank you so much.
Thank you. Thank you so much, all of you, for the kind opportunity and taking out time. Hope that helps.
Yeah. And I think rightly said, on the day of Teachers' Day, having such a beautiful class, I think the students will definitely benefit out of it.
Thank you very
Thank you,
much.
sir.
Thank you.
Thank you so
Thank you.
much.